approaches to the cervical spine. So, as we know, there are pathologies in cervical spine, maybe a disc problem or ossified ligamentum flavum, and all these problems can be tackled anterior and posteriorly. So we are going to keep it basic only from C2 to C7, anterior exposure and posterior exposure to the cervical spine. So what are the factors which you should consider before going anterior or posterior? You have a choice. So if there is a kyphosis, if it's a fixed one, mostly anterior is selected. If it's neutral or lordotic, we often choose the posterior approach. Levels, if there are more than 3 levels involved, if there are level 3 or more discs, then we go posteriorly. If less than 2, then we tend to go anteriorly. If it's a younger patient, most anterior approach is chosen. If there is pain or moderate to high, usually anterior and posterior both modalities are chosen. And if there is instability, obviously anterior and posterior both, or maybe anterior is the choice. So first approach is the Smith-Robinson's anterior approach, indication cervical radiculopathy for anterior cervical discectomy and fusion, for myelopathy patients for anterior corpectomy and fusion, in tumor patient maybe a corpectomy, infection and epidural abscess. So positioning, so you can see there is a positioning, you can position patient on a horseshoe also, on a garden well tongs also, or on a flat surface also where the neck is slightly extended and the patient, we recommend patient to keep the chin towards 10-degree rotated to the opposite side, so there is the proper exposure. So which approach to go, right or left? You can go any approach, but we choose left because the right recurrent laryngeal nerve you will have to expose and see. In left you don't have to expose and see the recurrent laryngeal nerve. It's in the carotid sheath. So where the incisions, the superficial landmark is, you can see hyoid bone, thyroid bone and cricoid. You can feel and palpate them. So at the level of hyoid, which is C4 to C5, is the thyroid cartilage, and it is the incision is usually C4 to C5 is on the thyroid cartilage. C6, C7 is on the cricoid cartilage. Other landmarks are the angle of jaw and sternocleidomastoid muscle. Angle of jaw is usually for submandibular approach and other approaches. So we go first from skin to the platysma. Platysma muscle is seen. Platysma is cut along the fibers. Under the platysma is external jugular vein, and also which surfaces along the sternocleidomastoid muscles. You see the vein and go medial to the sternocleidomastoid. So a plane is made between the strap muscles and sternocleidomastoid. When the plane is made between the sternocleidomastoid muscle and strap muscles, you go medially. You go medially and directly feel the bone. So you don't have any structures in between, you just go and feel and the bone which is medial. So try to be medial as possible and not to go lateral, because laterally you will find carotid sheath. So these are the structures which you will see. Once you reach the bone, you feel the bone, then you can take an incision on the prevertebral fascia also. And once you clear the prevertebral fascia, you will see longus colli muscle. Longus colli muscle should be dissected only 2 or 3 mm laterally, and then see and mark the level and then go for your procedure. So this is also one picture which shows how you have to go, how the incision is, and how you go between the sternocleidomastoid muscle, keep the carotid sheath laterally, and then go medially and find the vertebrae. This is one more picture which shows, first picture shows the where the platysma is cut, and the second picture shows where the disc level is. It's marked and confirmed. So some tips, you should always check your level on C-arm, and before inserting anything in the disc, you should confirm before preoperatively also the levels and intraoperatively also. Rotation of head 10 to 15 degrees to the opposite side should be done for proper exposure. Keep going medially. So if you see the finger, the more medial you go, you will find the vertebrae properly. Sometimes you palpate the transverse process and you feel that there is a bone, but the bone is medial to it. So that's it. And there is one omohyoid. If you go C4 and below level, you may have to cut the omohyoid. Second is posterior approach. Again, the indications are cervical radiculopathy, myelopathy, tumor and instability. Positioning is prone position, and again you can keep it on tongs, on a horseshoe or on a table also. and posterior exposure is done. Incision is using the landmark C2 and C7 are easily palpated. So between C2, C7, you can take a midline incision and cauterize. So you have to make sure that you go in the avascular raphe, which is there, which is the yellow line in between, and not go in the muscle. Once you go in the muscles, it starts bleeding. So avoid dissecting that. Go from the spinous process laterally, find the lamina and go to the lateral masses. This is one dissection which is done, one unilateral dissection to show you. So what is the extent laterally? So you see the lateral mass. If you want to put a lateral mass screw, you see the lateral border of the lateral masses and stop. If you want to do a laminoplasty or laminectomy, only the angle which is made from the lamina to the lateral mass is taken. So tips, again, check your level on C-arm intraoperatively. Don't just feel the C2 and the dip of C2 or C7. It might be something else. Head to be positional neutral because flexion and extension may give some trouble to you. As I said, avoid lateral dissection because it may cause bleeding. And many of the times C2 and C7, if you don't want to go there, you have to keep the ligaments intact because if you damage those, you may land up in kyphosis. Thank you so much.